Yeah. Thank you. Sound. I don't know Hindi. It's okay. It's fine because the fans, no, the fan sound will be there. So only I asked them to switch it off. The echo. Okay, but the sound, it's echoing. No, the one background noise is coming, no? Okay. Thank you. Yeah. A very good morning to one and all. I am Dr. Ranjith AR. I'll be taking the recent advancements according to Robbin's 10th edition. The Robbin's Basic Pathology 10th edition has come out. So this lecture basically will cover the advancements in Robbin's 10th edition, the latest advancements in WHO 2016, hematology, CNS, urogenital system, and also TNM staging or AJCC, American Joint Committee of Cancer Staging 8th edition, that was released in January 2017. All these are recent advancements, so I'll go slowly so that you can take notes and you can follow it. We'll go chapter wise. So first, a basic on what is apoptosis. We all know apoptosis is a type of cell death. Now there are 4 types of cell death: necrosis, apoptosis, necroptosis, and pyroptosis. Basically, apoptosis is a programmed cell death. The cell membrane is intact. There is no leakage of the cell contents as seen in necrosis, and there is no inflammation. And apoptosis can be both physiological as well as pathological. What Robbins is included is, we all know there were in 9th edition, there were few examples for physiological apoptosis and few examples for pathological apoptosis. What Robbins 10th edition has included is how it occurs, and they have included it in the form of a table. So more likely this will attract the question paper setters to ask new questions. So these are the conditions of physiological apoptosis. We'll see one by one how it occurs. Loss of growth factor signaling is the presumed mechanism for embryogenesis, that is thyroglossal duct, the disappearance of a thyroglossal duct or a notochord, those things, as well as turnover like intestinal epithelium, skin epithelium, the lymphocytes, and the thymus regressus. All these are due to the mechanism loss of the growth hormone signaling. And as it is easily understood that endometrium, when the hormonal levels are reduced, it will result in apoptosis. Whereas in immune and inflammatory response, the leukocyte number, for example, there's an acute inflammation. Following that, lots of neutrophils come. So at the end of inflammation, or the bacteria has been removed, these neutrophils should die, because chemotaxis is a unidirectional movement. For that, loss of survival signals for the neutrophils, that is, survival signals for the neutrophils here are interleukins. When the interleukins are lost, that triggers apoptosis. That's the mechanism of apoptosis for decline of leukocyte number following immune and inflammatory response. Elimination of potential harmful self-reactive lymphocytes. This is the mechanism for immunological tolerance. What prevents my body against autoimmunity, which means during birth my self-reacting lymphocytes will be presented to the thymus. How they are removed? That's because their apoptosis occurs both by mitochondrial as well as death receptor pathway. If you go back to the steps of or phases of apoptosis, there is an initiator phase and an executioner phase. In initiator phase, there is mitochondrial as well as death receptor. Previously it was presumed the immunological tolerance is because of only death receptor. Now it is both mitochondrial as well as death receptor pathway. So again I am repeating, mechanism of apoptosis in physiological conditions, embryogenesis and turnover of proliferative tissue is because of loss of growth factor signaling. Hormone dependent endometrial menstrual cycle, that's because of decrease in hormonal levels of red. Then after inflammation, the leukocyte number decreases because of loss of the survival signals, that's nothing but the interleukins. And immunological tolerance, it's now both by death receptor as well as mitochondrial pathway. Now I'll come to pathological apoptosis. This has a bit of change. So if there is a DNA damage, for example if there is a mutation, and if once there is a mutation, what will happen? My p53 will come into it and try to repair it. If it's not repairable, it will lead to apoptosis. If it is not repairable, it will lead to apoptosis. That pathway is, it directly activates BH3 only sensors. There are few proteins called BH3 only proteins. They are BIM, BIT, BAT, PUMA and NOXA. These are called BH3 only proteins. You must have known they play a vital role in the mechanism of apoptosis. Here when there is a DNA damage, when p53 is activated, among these particularly PUMA is responsible for p53 induced apoptosis. If there is one option to choose, you choose PUMA. The next comes misfolded protein. Example, there is a cystic fibrosis. So cystic fibrosis, there are various types of mutation. One of them is the protein folding into a complex quaternary structure. The folding is defective. So when the folding is defective, the cell undergoes death. This is important especially for PGI. If you note, accumulation of misfolded protein can directly induce BH3 only sensors, as well as it can directly activate caspases. This is a peculiarity that it can directly activate the caspases. So there are two options, BH3 only sensors and direct activation of caspases. This for PGI. For infections, especially viral infections, they activate the mitochondrial pathway. This is important, and not the what pathway? The other pathway is membranous or the extrinsic pathway. They don't activate the extrinsic pathway, they activate the mitochondrial pathway when there is a viral infection. So I am repeating it again. There are three changes. One is when there is a DNA damage, there is going to be an activation, or the pro-apoptotic BH3 only proteins will be activated. In misfolded proteins, there are two types: BH3 only protein activation or direct activation of caspases. In viral infection, it's going to be mitochondrial pathway activation. We'll go to the next step. So just I have designed an MCQ based on the new changes in Robbins. All of the following are due to effect of misfolded protein that result in ER-induced cell loss except. This is entirely a new question because this concept of ER-induced cell loss is new one. I'll tell what it is. So we'll assume that there is a cell. In this cell, due to some mutation, we'll take cystic fibrosis or a hypercholesterolemia where LDL is mutated. Due to some mutation, there is accumulation of misfolded protein. So the misfolded protein is something abnormal. So this will have a stress on endoplasmic reticulum. This will have a stress on endoplasmic reticulum. So what my endoplasmic reticulum will do is, there are two things. One, there is an accumulation of abnormal protein. So what should be my body's response initially is, it should decrease the production of protein. Yes? When the production is decreased, the number of abnormal protein is going to decrease. Right, that's first one. Or if the accumulation is much more than expected, I can't do anything, what my body will do is, it will cause cell loss or cell death by apoptosis. It will cause destruction of this entire cell. That's the second step. Okay, see, I'm coming back again to the previous screen. Misfolded protein as a result of ER-induced cell loss. This ER-induced cell loss is the second step. ER, that is endoplasmic reticulum, induced cell loss. So what decides this? What decides that it should be decrease in production or a ER-induced cell loss is one thing called IRE1. This is needed. This is what decides whether it should go to cell loss or go to decrease in production. This can be asked as an MCQ. The deciding factor. First MCQ. So previously there was a table of 5 or 6 diseases like cystic fibrosis, hypercholesterolemia, Tay-Sachs. All of them were misfolded protein. Now what Robbins has done is, it has divided it into diseases which follow degradation of protein, that is the first step, and diseases which follow ER-induced cell loss, that's the second step, and diseases which follow both. That's the basis of the question which I asked. So which all disease will follow degradation of protein? Which all disease will follow the degradation of protein is cystic fibrosis, familial hypercholesterolemia, Tay-Sachs. So in these diseases, the accumulation of protein, damaged protein, so production will be decreased or degraded. The mutant protein will be degraded. So cystic fibrosis transporter will not be present. LDL transporter will not be present. Exosome beta subunit will not be present. They will be loosed or they will be degraded because it is abnormal. The second one is ER-induced cell loss. So diseases which have ER-induced cell loss are retinitis pigmentosa, Creutzfeldt-Jakob, that's prion disease, and Alzheimer's. Here what happens? The entire cell is lost. That is ER-induced cell loss. Great. So what will be one disease which have both these features is alpha-1 antitrypsin. Both degradation as well as ER-induced cell loss is alpha-1 antitrypsin deficiency. Now we'll come back to the question again. All of the following are due to the effect of misfolded protein that result in ER-induced cell loss, which means all these three are ER-induced cell loss. So which of them is not except question? So answer will be cystic fibrosis. Answer is cystic fibrosis, which is because of protein degradation. Okay, I'm repeating it again. So a normal cell accumulates a degraded protein or a mutated abnormal protein. So my body's thing is it will decrease its production and degrade the abnormal protein. That's the first step. So few diseases like cystic fibrosis, familial hypercholesterolemia, and Tay-Sachs follow this method. In some cases, when the amount of protein is more, this IRE will be stimulated and the cell will be entirely destroyed. So these some diseases follow this step only are the retinitis pigmentosa, Creutzfeldt-Jakob, and Alzheimer's disease. Kindly note this down because these are potential MCQ points. One, it has been in the form of a table, so it can be all except questions can easily be framed on this. Another, it's a new concept. So questions based on endoplasmic reticulum induced cell loss. One, the IRE, that's a triggering factor. So what are the types it can occur? Yeah, repeat with me, it's degradation of proteins or apoptosis. So what are all the diseases which go based on that? There are three divisions. One, only with degradation, only with ER induced cell loss, or both. Fine. We'll come to the next one. The next one is, this was asked in recent NEET, so I've just included that. This is not any advancement, but it's new topic. Samoma body occurs at, what is a Samoma body? We know Samoma body is a dystrophic calcification seen in papillary carcinoma thyroid. Right. So it's seen in multiple other neoplasms also. The question was, where does it occur? The tip, base, body, or none of the above? So what's a papilla? Papilla is nothing but a finger-like projection. We all know this. We all know the answer of this. It's very easy, but the thought process will not work at the time of exams. So it's a finger-like projection with a central fibrovascular core. Okay. So if it is like this, tell me which part of the papilla, tip, base, body, which part of the papilla will have decreased blood supply? It's so easy. It's the tip. So if there's a decreased blood supply, in other terms it's ischemia. So the tip will be having ischemic effect. So the tip will undergo necrosis. Whenever there is necrosis, there is more chance of dystrophic calcification. Dystrophic means in diseased tissue. Whenever there is necrosis, obviously there is more chance of dystrophic calcification. That is nothing but the Samoma bodies. So now we will come back. So the dystrophic calcification occurs at the site of necrosis, where the necrosis is common in the tip of the papilla, because the blood supply to the tip of the papilla is reduced compared to the rest of the papilla. That's as simple as that. So the tip of the papilla was the answer. There's one more extrapolation of this concept is, so any tumor with papillary architecture will have Samoma bodies. Means, because each time when you read the Samoma body, tumors which develop Samoma body keeps on increasing. So this is one clue if a PGI question comes, and if you know one of the options is, for example, lung carcinoma. Lung carcinoma has a papillary variant. Excellent. It will have Samoma bodies. Serous adenocarcinoma of ovary, it is papilla, so it will have Samoma bodies. Papillary thyroid carcinoma, papillary carcinoma of breast, papillary renal cell carcinoma, all these can have Samoma bodies. So we have learned two things. It's like on the tip of the papilla, and any tumor with a papillary architecture will have Samoma bodies. Great. So next advancement in the last one in the first chapter is aging. There are various theories of aging. The telomere shortening, the accumulation of free radical induced DNA damage, the recent link between aging and food intake. These are all old theories. What they now propose is chronic inflammation leads to aging. So whenever you have a chronic inflammation, it leads to aging. So that's okay. That's understood. Whenever there's a chronic inflammation, there's going to be increase in reactive oxygen species. So there's going to be aging. What's new in this? They propose that the chronic inflammation will activate the process of pyroptosis. That's an MCQ point. So which of the cell death or mechanism of cell death, which of the mechanism of cell death is involved in aging process? The answer should be pyroptosis. If there's a question asked in future, the answer should be pyroptosis. What is proposed, that is, chronic inflammation activates pyroptosis, and which causes aging. The exact link is not known, but this is a potential MCQ point. Please note down. Mechanism of aging, the pathway of cell death involved is pyroptosis and not any of the rest of the three. Right? Okay? Fine. We'll go to the next chapter. Inflammation. Okay, what's the answer for this? The immediate and transient response of vascular permeability is because of this or this or this. Which one? Okay. The 9th edition of Robbin said it is this. Okay, this is one of the most controversial and one of the most frequently repeated one. Okay, the 8th edition had a concept. The 9th edition had a different concept. Now the 10th edition is again having a different concept altogether. We'll see all the three. It was said that contraction is for transient response. The endothelial cell contraction is for transient response and retraction is for delayed and prolonged response. This was the concept in Robbin's 8th edition. When 9th edition came, it was so clear, they removed all this confusion and said immediate and transient response is because of endothelial cell contraction. It was so damn clear. There's no confusion at all. What they have done now is the same immediate and transient response, now it has been told it's because of endothelial retraction. Okay. So now what do you choose when this question comes? My thing is, if this question comes in aims, go for contraction, because the Robbins 10th edition is not yet out in India and it is not so widely read now. So now go for contraction. If the same question comes in NBE NEET, that's going to happen in December, go for retraction, because that time the concepts would have been definitely changed and everyone would have got the new Robbins and they would have changed the concept. See, this is what I said. This is Robbins 10th edition. Retraction of endothelial cells is the cause for immediate and transient response. See, the same thing, the same picture from Robbins 9th edition. It's contraction of endothelial cells. Okay, the Robbins 9 said contraction. For this aims May 17, that's going to happen 1 week, go for this option. For NBE 2017 November December, go for this option. Okay, is it clear now? Okay, great. This is one of the most important and repeatedly asked, and it has been a controversy forever, and now Robbins, what the 10th edition have done is it has aggravated the controversy. That's all. We all know what is neutrophilic extracellular trap. This term is introduced in Robbins 10th. Netosis. There are few diseases which are because of this neutrophilic extracellular trap. Those diseases are categorized into netosis. First we'll see what is extracellular trap. It's called a beneficial suicide. Okay, so I'll come to this picture again. So what is the purpose of a neutrophilic extracellular trap? It is said that there are 4-5 neutrophils, and there is a bacteria coming out. For example, we'll have some bacteria. For okay, Neisseria bacteria is coming. So what my neutrophils will do is, it will form a meshwork. It will kill themselves into it. Like it will secrete all its granule contents, the nuclear meshwork, everything will be secreted. So all this Neisseria will be trapped. That's why it's called a trap. Will be trapped in this like a spider's web. It will be trapped like a spider's web. So it will be easy for the neutrophils for easy killing. That's why it's called a beneficial suicide. It is beneficial and it undergoes suicide. These are electron microscopic picture from Robbin. See, these are the granule contents and this is the trap. See, this is a trap where it is secreting it. It contains nuclear chromatin, histone and DNA. So what is amusing about this is, why do you have to know this? Anything you read should have an implication. If there's no implication, there's no purpose of reading. So can you just think for one moment, this is a beneficial thing, this is useful for us. So what is harmful in this? What is the harm? What is the harm of neutrophilic extracellular trap? See here, it is clearly written, it's an extracellular fibrillary network. Means this trap is occurring in the plasma. Means the contents of the neutrophils, the contents are out in the plasma, right? So what are the contents? The nuclear contents, DNA, histones, and obviously the granule contents, the neutrophil granules, MPO, proteinase and all those things. Does it ring a bell? Does it strike anything? I'll give 2 seconds. Just think about it. Does it strike anything? If you have got it, you are excellent. So these things are there in the plasma, which is abnormal. So what my body will do? Extraordinary. My body will produce antibodies against this. Right? That's my body's work. My body will produce antibodies against this. Antibody to DNA. What will have? SLE. Cute. Antibody to histone. Drug-induced lupus. Again lupus. Antibodies to MPO. What is that? Proteinase. What is that? ANCA. Great. So all these diseases are now classified into netosis. Awesome, right? All these diseases are now classified into netosis. It's systemic lupus erythematosus and ANCA-mediated vasculitis. These both diseases are now classified into netosis, and this is given in Robbin's 10th. So there are furthermore diseases classified under netosis, but as of now these two are the prime importance. So now I know what is the basis of netosis. Come on, it's amusing. When you know a basis of something, you can have a therapeutic option. So if I can somehow prevent this antibody formation, I can actually prevent SLE and prevent vasculitis. That's going to be great. Okay, so this is the concept of neutrophilic extracellular trap and netosis. I am repeating again. Neutrophilic extracellular trap is a beneficial suicide. What it does is, neutrophils come together like a spider web. They secrete their contents and trap the bacteria, and they kill them. So this is useful for me. What is harmful is, the contents of the neutrophil will go into the plasma. That's the DNA, histone, the MPO and the proteinase of the granules, of the neutrophilic granules. So when this comes out into plasma, my body's intrinsic response is to produce antibodies against this. So when it produces antibodies, it will result in diseases called of SLE, systemic lupus erythematosus, and ANCA-mediated vasculitis. These both are now called as netosis. Okay, we'll go to immunology. Which of the following is the best way to differentiate lymphoma mimics from lymphoma? The final answer is histopathology, because we have read histopathology is gold standard. This was there in previous edition of Robbins also, because it was not given much importance. I am including this here. But the answer is antigen receptor rearrangement. This is the best method, because histopathology I'll have a confusion. Using IHC also sometimes I'll have a confusion, but with this method there will be 100% specificity and sensitivity. It's going to be 100%. If this is not there in the option, definitely you should go for histopathology. If this is there in the option, or if PCR is there in the option, go for this. I'll tell what is this. Okay, this is a T cell receptor. This is a normal structure of a T cell receptor. It's there all over. It's there in Robbins. These things are MCQs which have been asked. Ignore them now. So this alpha and beta chains, this is a site where the antigen binds. So this site will have recombination called VDJ recombination. You must have heard of this. Similarly, in B cells, what we have is the variable chain of immunoglobulin. Right? So this is what it decides. Streptococcus will have a particular VDJ. Staphylococcus will have a particular VDJ. Everything will have a particular VDJ. That's why there is a diversity. This is responsible for the diversity of the adaptive immunity. Right? So there are combinations. Both. It has combinations. So each one will have permutation combinations. That's why there is diversity. This, okay. So what is antigen receptor gene rearrangement is, I'll take a lymphocyte, some 10 lymphocytes, and I'll be able to say what is the VDJ recombination in this. Or I'll take some immunoglobulins, 10 to 20 immunoglobulins, and I'll be able to say what is the VDJ recombination in this particular thing. So how it is useful for a neoplasm? How? We all know neoplasm is, or a tumor is, a unique thing. It is monoclonal. It's going to come from a single cell. If there's an infection, it's going to be, it will be always polyclonal. So if I have a doubt, I'll take all these lymphocytes and do a PCR, and I'll be able to say all the 100 lymphocytes have the same VDJ combination. Then obviously all these are monoclonal. It can never be an infection. If all 100 are having the same VDJ combination, it can never be an infection. It should be a neoplasm. That's why this is the best. This is the best. If this is there in the option, go for this. If this is not there, then obviously histopathology and IHC is the answer. Right? So VDJ recombination is for my diversity, the T cell diversity of an adaptive immunity. My T cell receptors has intrinsic combination of different chains. Similarly for immunoglobulin also. So if this VDJ recombination is same across 100 or 1000 lymphocytes, it is monoclonal. If it is monoclonal, it should be a neoplasm and never an infection. That's why this is superior to histopathology. Right? Great. The answer must be antigen receptor rearrangement. Okay. This is a famous question. Which gene codes MHC? Spinal response, chromosome 6. Easy. Which chromosome? Chromosome 6. Okay. And look for this PGMR. You know, each time they add few things. MHC or HLA is coded by chromosome 6p21.3. What they have added now is one more chromosome they have added. One extra chromosome they have added. Class 1 and Class 2 MHC, the structure is different. You have alpha 1, you have alpha 2, and you have alpha 3 domain and a beta 2 microglobulin in Class 1. Class 2 you have alpha and beta chain. Now it is said the Robbin 6th edition has added this point. The beta 2 microglobulin polypeptide is separately coded by chromosome 15. It means this beta 2 microglobulin is coded by chromosome 15. The rest are all coded by chromosome 6. So now we have two chromosomes to remember for HLA or MHC, right? There are two chromosomes. Again look here. The answer is chromosome 6 and 15. Again look, if MHC is asked, safe bet is chromosome 6 if it is a neat question. If specifically beta 2 microglobulin chain is asked, the safe bet is going to be chromosome 15 in neat. Okay, your answer differs on the question. Read the question. If it is in general MHC, it is chromosome 6 because majority is coded by chromosome 6. If it is specifically beta 2 microglobulin chain of MHC1, which chromosome is coding? It is chromosome 15. It's a theoretical fact and you have to know this, especially for PGI questions, because this no one will write, no one will know unless you have listened to this class or you have read the new recent advancements. Okay, so we know this. This was there in the previous edition of Robbins only. The nod-like receptors. There are membranous, plasma membrane, cytoplasmic and nuclear receptors. The famous is toll-like receptor. I am not going to it. The other ones are nod-like receptors. Previously in Robbins it had rig-like receptors. That's all. Now it has added one more receptor. I'll come to it. Nod-like receptor is cytosolic and it activates caspase 1, which will result in what type of cell death? Again, pyroptosis. So conditions associated are inflammatory bowel disease, periodic fevers, that is the familial, Mediterranean fever, and gout. What Robbins 10th has added is cytosolic DNA sensors. This is important. This is a potential MCQ. Robbins 9th had rig-like receptors will detect both DNA and RNA. What Robbins 10th says is rig-like receptors only detects DNA. Okay, see the change. Carefully note the change. It detects only RNA, and cytosolic DNA sensors detects DNA. All these are related to viruses. So this is a new addition. Look for the question in PGI maybe, which of the following are receptors of recognition? Look for this option also. Receptors of recognition. It can be toll-like receptors, nod-like receptors, rig-like receptors, and look for this one also. Or in NEAT, the question may be DNA viruses or DNA in the cytoplasm of any organism is detected by. That time the question should be cytosolic DNA sensors and not rig-like receptors. Rig-like receptors was an old concept for DNA and not rig-like receptors. Okay, two things have been added: MHC, chromosomes 15, and cytosolic DNA receptors. Okay, SLE. SLE is a prototype of autoimmune disease. SLE has type 3 hypersensitivity. SLE has fibrinoid necrosis. SLE, there are many antibodies and many MCQs comes on SLE. What is new here in Robbins 10th is there's a clinical criteria, right? Clinical criteria for SLE. And this is one famous mnemonic, you must be knowing it. So Brain MD. If 4 of 11 criteria are present, you can clinically diagnose it as SLE. In the immunological phenomenon, they have added two more extra criteria. This is new. What are they? They are low complement level, low C3, low C4 or CH50. It's a test done to detect complement levels. Okay, or a direct Coombs test positive. Look here, the beauty is this: a positive direct Coombs test in the absence of clinically evident hemolytic anemia. That is the catch.